welcome back. What we're going to do in this lesson is we're going to go farther into Kathy's examination, and now we're going to actually examine her temporomandibular joints. In the previous lesson, we discovered that she had a lot of muscle discomfort all on the left side. Interestingly enough, on the right side, she basically had no muscle discomfort at all, except her right medial pterygoid was a little bit uncomfortable. So when we think about examining the temporomandibular joint, what we're trying to do is really identify the condition of the joint. And there's different levels at which we can go into the examination, all the way up to MRIs and CBCTs, and so the need for imaging. What I want to talk about right now is more of what do you do clinically to sort of start to build the case for who needs a more involved data collection, who needs imaging compared to just a simple clinical exam. So when we think about the joint, what I do is I use a lot of palpation, and so we know sometimes we can get patients that have a capsulitis, a capsule that surrounds the joint. Sometimes we can also get tenderness in the retrodiscal area. And so the video you're going to see is how I palpate the capsule and also the retrodiscal area. And as in the previous lesson, I'm going to be just walking through it and talking to the students that are observing it. And you'll get to see Kathy's response as to whether there's any discomfort or not. And when I do retrodiscal tissue, what I like to do is use my little finger in the ear canal and just light pressure. But to make sure I'm in the correct place, I have the patient actually open and close so I can feel the condyle bumping against my finger, and I'm compressing that tissue to see if there's any tenderness, which if that tissue is highly inflamed, there typically is. So what I'm going to do is just a simple palpation to see if I feel any popping or clicking. Go ahead and open one, close, again, close. Do you feel anything making noise? Okay, I don't either, so I don't feel anything there. I'm going to turn her head sideways, and I want to palpate the lateral pole of the joint where the capsule is. So go ahead and open, close, again, close. Is that tender at all? Okay, so right over the condyle is not bothering her. Go ahead and open, close, again, close. Stay closed. Any tenderness there? Okay, and I want you to notice what I'm doing with my finger is pushing down and forward, so I make sure I'm pinching the retrodiscal tissue between my fingertip and the condyle. And to know I'm in the right spot, go ahead and open and close. Watch my finger bounce as the condyle hits it. Okay. So on the left side, which is the side she's experiencing the discomfort, if you remember from the previous lesson, she's rating that area as around a 4 when we were doing the muscle examination of masseter, temporalis, etc. 3 days earlier, when she couldn't bite on her teeth, she was rating the pain there at about an 11 out of 10. Today, so far, nothing in terms of palpation discomfort. Now, next thing we're going to do, and her right side's also totally comfortable, is we're going to actually measure her opening. So we're going to watch her maximum opening and measure it. Typically between the incisal edges, 35 to 50 would be kind of a normal maximum opening. We're also going to watch as she opens, does her mandible open straight or does it deviate off to the side? When the mandible deviates off to one side, what it's doing is it's deviating to the side that the condyle is not translating. So if we had a problem such as a disc that was displaced and was sticky, the mandible will oftentimes move towards that side, and finally when the condyle jumps on the disc, the mandible moves back to center again. And if you have the same problem in both joints, you'll see somebody that opens one direction and all of a sudden snaps on, goes back this way, and then snaps back to the middle. And then finally, we're also going to measure lateral movement using the midlines of the upper relative to the midline of the lower, and kind of 8 to 12 millimeters would be a real typical range of lateral motion. And I use a little measurement device that comes from Great Lakes Orthodontics. It's a simple little ruler that you're going to see in the video. Now what we're going to do is actually have her go maximum opening, then left and right. What we're really also looking for is, does she have any discomfort with movement? So go ahead and open as wide as you can. get it so I can at least read the scale. So she opens about 47, so well within normal. Any discomfort with that? Okay. And her midline is off about 1.5 to the right, actually 2 to the right. So when I have her move left and right, I've got to take that into consideration. Move as far right as you can. And close up just a little bit for me. So she's over about 12, but she actually started to that direction, so she's going 10 to the right. Move as far left as you can. And she's about 9, but we need to add 2, so she's about 11. Again, we're just looking to see, does she translate the same both directions? And certainly she's within a millimeter, and it's 10 and 11. And any discomfort when you're translating? Okay. So my initial palpation didn't find anything. Her movements are totally normal. When she opens straight. She opens 47 millimeters. She moves left and right 10 and 11 millimeters. So far, her jaw joints don't seem to be part of our problem. And when she was doing the movements, she also wasn't uncomfortable at all. So the other tool that I use as part of my initial examination is I use a Doppler, which is ultrasound. There's other devices such as joint vibration analysis that are also helpful. The reason I like the Doppler is quite simple. It's because the patient gets to hear it because it has a speaker attached to it. So what I do is I tell the patient that a normal jaw joint actually is quiet. It makes no noise. Now, if they move real fast, this Doppler's tuned to a certain speed of opening. So I have them open real fast initially so I can help aim the Doppler directly at the joint, because when they're moving fast, it will be noisy. Then we're going to have her slow down, close on her back teeth, put her tongue to the roof of her mouth, just open about a 1/2 inch or 1 centimeter. So we're just checking the rotation of the joint to see if we hear anything. That's more towards the medial pole of the joint. And then we're going to have her slowly open as wide as she can, taking about a second to fully open. And now we're going to be listening for translation. Again, what we're listening for is we're listening for noise with rotation or noise on translation. The Doppler's not diagnostic. It's not going to tell us for sure whether the medial part of the disc or the lateral part of the disc is displaced. But if there's noise in the joint, we will start suspecting that something in that joint is not normal. And again, that would start tilting us towards perhaps doing some kind of imaging. Go ahead and open again. Close. And real fast. Okay. So what I did, just to go through it again, is I'm coming in basically perpendicular right at the back of the fossa. So the superficial temporal artery is running right at the back of the fossa. I'm aiming the Doppler down at the head of her condyle, having her open and close real fast. And you notice I don't hear much. It's not very loud, not very scratchy. So I'm moving it until I find the loudest spot. Now I want you to bite on your back teeth. Put your tongue to the roof of your mouth. And just open and close a 1/2 inch. And that's just checking the medial pole by checking rotation. Close. Now I want you to slowly open as wide as you can. And close. And again. Close. Okay. So we got all these muscles bracing the left side. What does it look like they're not having to brace? The joint. The joint's quiet as can be. In Kathy's case, again, we're talking about what kinds of patients do we think about really benefit from appliances. And I mentioned in the previous lesson patients with muscle issues. And if she did have a temporomandibular joint issue, it would definitely also impact the type of appliance we need to use. So far, her joints seem awfully normal. And I did the Doppler on the right side as well, and that's also totally silent. So just to review again, what we're trying to find out by listening to the jaw joints is we're really trying to identify where's the disc, and is the disc sitting in the right place. And these images are from Jimmy McKee, and they're really helpful to understand what we're trying to do. When we have a structurally intact normal joint, essentially what we have is we have the disc covering the medial and lateral part of that condyle. And as the patient opens and moves, the disc always stays in the correct location. The more common patient we see in practice who has clicking and popping has what we'll describe as a structurally altered disc at the lateral pole. So if we were to look, and if you look at the little ovals I just pasted over each joint, what happens in this type of patient is the medial pole of the joint stays where it belongs. The medial pole of the disc stays where it belongs, but the lateral pole rotates anteriorly. And so we call that an anteriorly displaced disc, but it's only the lateral portion of the disc that's rotated forward, and that's what produces the clicking and popping when the condyle jumps on it. The joint that is the highest risk for us is, in fact, when the disc completely dislocates anteriorly. And so as you see those little ovals move forward, now the entire disc is anterior. That joint can now lose vertical dimension. You can get occlusal changes. It can become uncomfortable when you try and seat condyles. And so we typically, with our exam that we're doing, our palpation and our Doppler, is Kathy really looks like she belongs in that structurally intact zone. Her joints sound normal, so I would give her a green light that, yeah, she's probably not a joint patient. When we have patients who have the medial pole still intact, it means we can still seat the condyle, so they're green in terms of how we manage their bite. They may have symptoms, so we'll kind of give them a yellow caution. When they translate, sometimes they might have symptoms. The dangerous patients really are the ones who've completely lost the disc, because in fact they can have changes in their bite, they can have discomfort in the joint, and so they're sort of either a yellow caution sign or a red, you need to manage the joint before you do anything else. So the last part of the exam I'm going to do on the joint is what we call load testing. And load testing is not infallible. It can give you some false readings. But what load testing is we intentionally try and seat the condyle with force so that we see if there are any symptoms or not when we do that. If there's discomfort in the area of the joint when we seat the condyle, oftentimes it's the lateral pterygoid muscle, because if the lateral pterygoid is trying to hold the condyle forward, when we seat the condyle, it's trying to stretch the lateral pterygoid. It also may be that, in fact, there's inflamed retrodiscal tissue. It also may be that, in fact, we have an internal derangement where the entire disc is displaced anterior, the medial and lateral pole. So a load test, if it's positive, tells us something's not right. If it's negative, for years we always believed that that meant the joint was healthy and stable. That turns out it may not necessarily be true, but a positive load test for sure tells us we have to look further. And again, if it's the lateral pterygoid muscle, where will they experience discomfort? Right in front of the ear if it's the inferior belly, right below the eye if it's the superior belly. So now what we want to do is move into load testing, because load testing is going to be the last thing we do, which is going to evaluate retrodiscal inflammation, which we did with our finger and didn't find any. We're going to evaluate the joints receiving of load, which I think is going to be fine because the discs sound like they're right where they should be. But it's really going to test lateral pterygoid. And so we'll come in with the leaf gauge. And I just want to put enough leaves in there initially that she's not going to hit on her back teeth. Go ahead and bite down and slide forward, back, and squeeze. Any tension anywhere? Mm-hmm. Okay. Right, that's exactly what I would have expected her to say, given her symptoms of the past few days. So do that again, bite down, slide forward, back, squeeze, and point to where it say at again. Right in front of the ear. Okay. And I'm guessing by your face that's...
Kind of let go.
Okay. So on a 0 to 10, how uncomfortable?
It's like an 8.
Okay. Okay, so there's multiple ways to load test. Pete Dawson teaches to load test using bilateral manipulation where you apply the force. I load test typically with an anterior deprogrammer. I use a leaf gauge because it's quick and easy. we put in enough leaves in the leaf gauge so that when they go forward and back, their posterior teeth don't touch. And it's quite simple. It's slide your jaw forward, let your jaw go back, lightly squeeze. Kathy has a positive load test. Her load test was an 8 out of 10. And again, remember, this is after 3 days being on an aqualizer, non-steroidal anti-inflammatories, and muscle relaxant. So something is really uncomfortable in there, and the most likely candidate is actually the lateral pterygoid muscle. So what I'm going to do next is I'm going to actually have her clench on cotton rolls. And the reason we do the clenching on cotton rolls is we try and see if we can get the elevator muscles, which are very large, to actually seat the condyle and stretch the lateral pterygoid. And about half the time, if you do the clenching on cotton rolls on second molars, the patient actually, when you retest them with the leaf gauge, they feel comfortable. Then you know, in fact, it was lateral pterygoid muscle, not joint. So we're going to see if we can accelerate the release of those pterygoids. And the way we're going to do it is we're going to hit the elevator muscles against the lateral pterygoid. Because as soon as I put the cotton rolls on her second molars and ask her to squeeze, it will fire the elevators completely, which will seat the condyle. The only thing that can possibly keep it from seating is the lateral pterygoids, because the cotton rolls are still in front of the masseter. So the cotton rolls won't keep the condyle from seating. What they do is they trigger the masseter to fire completely. And so I'm going to put these in on her second molars. And I'm going to ask her to close on her back teeth and clench as hard as she can. And open. Do it again. Open. Do it again. Open. Do it again. Open. Do it again. Open. Okay. Now we immediately come back to the leaf gauge again. Bite down. Forward, back, squeeze. Any difference or no?
No, I'm still tender.
Still tender.
Mm-hmm.
Okay. So what I would do now, given that the cotton rolls didn't work, is I'd make her a Lucia jig. And so when I say what I would do now is make her a Lucia jig, assuming you have time in your schedule as part of this exam, what I would typically do is make a Lucia jig that is made on the central incisors, and I would have the patient actually go out in the reception room and just sit and read a magazine for 20 or 30 minutes. The purpose of the Lucia jig is to see if we can deprogram the pterygoids. And believe it or not, in a lot of people, 20 or 30 minutes with a Lucia jig in, you can redo the load test and there'll be significantly less discomfort. Again, in which case it's telling you it's not a joint problem, most likely it's a pterygoid problem. So we'll walk through how do we make the Lucia jig, right? Because we still don't know, is it a pterygoid problem, retrodiscal tissue, internal derangement? We don't know. We just know we have a positive load test, discomfort with loading. So we'll use the pre-made Lucia jig. The video will show how it's relined using what we call a whale tail to make it parallel to the occlusal plane. And what I want you to watch in this video is I'm going to have her slide forward and back on the Lucia jig using red articulating ribbon. I want to try and get the Lucia jig adjusted so the marks come right out of the center of it. And then I'm going to have her go as far retruded as she can, and I'm going to have her tap using black articulating ribbon. Then we're just going to set her back a little farther and have her open and close by herself to see if her lower incisors close on that Lucia jig in the exact same spot each time. If they don't, what you're watching is her lateral pterygoid muscles kind of going crazy. So here, watch the video and you'll see what happens. Bite down. So there's our little whale tail with the Lucia jig. So we'll use red ribbon first and bite down, slide forward, back, open. And I'm looking to see where she's hitting. Looks like she's only hitting off to that left side to me. Okay. Bite down, forward, back, open. So now we're coming right out of the center of it. And if you want to see what somebody's lateral pterygoid's doing, Good, red again. Bite down, forward, back, open just a little. Give me that for just a second. Tap, tap lightly, open. So now what I've done is I've marked the most retruded position she goes with that little black spot. I'm going to put this back in, have you tip your head way back, and I want you to see if when she closes all by herself, let's see if we're going to be able to see this, she closes on that dark spot. Hold on. Go ahead and just start to close. Open. Again. Open. She moved forward that time. Do you see that? That time she's back. Up there she goes. So
I don't know where to close.
exactly. So every time she closed in a different position. And did you hear what she said at the end? I don't know where to close. Kathy right now has a lateral pterygoid on the left side apparently that's just out of control. And what it's doing is it's moving her mandible all over the place. The last thing in the world you'd want to do right now is touch her teeth with any kind of a burr to adjust her bite. She's the patient who could come in and say, I woke up this morning, I'm hitting here, and you adjust it, and the next thing you know, she says, well, now I hit here, and you adjust it, and now it's here, and 20 minutes goes by, and you're adjusting all over the place, and you have no idea why, and it's because her mandible's closing in a different place every time she closes. Kathy is the perfect patient for an appliance. Now, as I said, in future lessons, we're going to talk about what kind of appliance. But my sense for Kathy is her joints are fine. And so to me, I usually use some sort of an anterior deprogramming appliance, such as an anterior bite plane. Now, just to show you how fast she responded to sitting on the Lucia jig, I'm going to show you a video of her closing into that. We remarked her most retruded position after about 20 minutes. And watch how she now closes on the Lucia jig. She closes into that black spot every single time, like absolute certainty, because now the pterygoid let go and she's back into a more normal position. Close, open, close, open, close, again. Excellent. So what I hope you're taking away from this lesson and the previous one is this is the kind of patient who really we think about building occlusal appliances for. What did I do for her? I just made a chairside anterior bite plane. She wore that chairside anterior bite plane literally for 24 hours, and she was totally comfortable. Now, I wouldn't have her I wouldn't trust that her muscles are completely relaxed yet. I would have her wear it about 8 hours a night for a couple weeks to help continue deprogramming. But what it tells us is her jaw joints are actually fine. And so what we do with patients like Kathy is we go through the muscle exam, we go through the joint exam, and then we really make some decisions. Do we change her occlusion, or if she needed some restorative dentistry, do we just treat her as she is? If she's comfortable again, maybe you consider treating her as she is. Myself, what I would do is I'd deprogram her for a couple weeks, and then I would get mounted models so I can really evaluate her bite from a seated condylar position to see if I think she would benefit from some form of occlusal equilibration. And so for myself, if I was going to restore her, I would probably consider altering her bite after she's deprogrammed. What my exam has told me is what I wouldn't do is need to refer her for more imaging or to somebody who manages facial pain, because I think Kathy really has a muscle issue. So ultimately, what I wanted to do in these first two lessons is give you kind of a good visual of who is the patient that really does benefit a lot from occlusal appliance therapy. And now as we move into subsequent lessons, we're going to talk about what kinds of appliances for different patients. So look forward to seeing you there.